Thank you so much. And it's wonderful to see so many people here today. And I'd like to share with you a bit about OpenEHR and what it is, but via my journey as a CIO. And it'd be great to hear, in the chat a bit about your backgrounds and who you are, because I think many of us have worked in health systems. And I've tried to relay really this journey as part of my journey, really, how I discovered OpenEHR and how I've used OpenEHR as well, and then how I became the CEO of OpenEHR. So first of all, you've heard a bit about my background. I've been a CIO. I've worked in global research and policy as well, both academically and in governments. I've looked after hospitals, healthcare systems, communities, and I've had roles in different parts of the health system. So I've had a pretty good view of healthcare. And for me, the reason I decided to stop being a CIO was I could see some of the things that were wrong. I understood what was wrong in health systems from all of these different roles. And I wanted to be part of making global healthcare better. And I wanted to work with global communities because what I found, certainly working in the UK health system, was we were duplicating effort with other countries. We were reinventing the wheel, as we say in England. We were doing things that others had already done. And we were allowing things to become too fragmented. And so I wanted to be part of the solution and not part of the problem. And so I decided probably 3 years ago that I was going to stop being a CIO. I'd keep my academic role, but I would actually seek to work globally on solutions and standards that would actually help us to bring in, the sort of environments that we need for AI and for advanced technologies. And it's been a really interesting journey, but I should probably start at the very beginning, or not the very beginning, but near the beginning of my journey. So I spent, 15 years or so as a CIO, a senior leader in healthcare. And my final job, my final CIO job, was at the Salford NCA group. And that's where I became most involved with OpenEHR. I'd already used it, but I became more involved there. And just to give you an idea of that organization, it's acute specialist care, trauma, community services, and adult social care. So it's an entire health system. It's got 20,000 staff. And it was the first of only 3 double outstanding trusts. And it was also the most digitally mature in the NHS by the time I left. So we had less than 1% of the paper that we had at the beginning of the journey. And so it was a place where there was very good leadership, and I was able to digitize, and we were able to get high satisfaction and quality of care with that digitization. So it was an amazing experience for me, and I had amazing people that I worked with. But the locality itself, it's in Greater Manchester. It's in the bottom decile for deprivation indicators. Large burden of industrial diseases, including COPD, and a very high unemployment rate, so 7.2% for men and 5% for women. But also the life expectancy in some of our boroughs was 10 years below that of the most wealthy boroughs. And so we had, some real health challenges. And it was an exciting place for me to be able to make a difference. But this was the environment I worked in, and we had over 1,000 different systems with clinical information in. Those systems had very different data models. They had very different ways of recording information. And I did an analysis with Carnegie Mellon University in the US about what was wrong with our environment. And the analysis came out that we had grossly unwarranted variation in our data. And that was a super interesting thing to sort of analyze, because I was finding it very hard to do things like home-based pathways or patient pathways involving the patient. And the reason was we just didn't have the space or the time to actually work on these new initiatives because of all of the legacy that we were living with. And so even though we were the most digitally mature in the NHS, we still had a huge amount of technical debt due to the historic way that we had bought systems or worked. And so it's a very educational place for me to measure some of that, to understand some of that, and to work out what health systems need for the future. Now, Salford's a great place. It's the home to the BBC, so the BBC HQ is there. My innovation space was above the BBC HQ. We had a lot of privilege and a lot of ability to, sort of do big projects there and innovate. But we still couldn't move as fast as we liked because of all of the things that we had to deal with. Our interoperability was incredibly complex with all the systems we had. And my view was that we needed to converge. We needed to converge on things that would make it easier for us to work on data science, work on advanced solutions and innovation. And, it's probably very typical of places that have digitized a lot over time. You've got too much variance in the systems and too much variance in the environment. So I came to this concept of unwarranted variation. Now, we talk about unwarranted variation in healthcare. So when we normally talk about unwarranted variation, we're talking about clinical care. So unwarranted variation in protocols or pathways or regimes. And we know that standardizing pathways gives benefit, it improves outcomes. And I looked at the UK, obviously where I was based, and ridding the NHS of unwarranted variation could save 5 billion a year. That was part of the BMJ findings. And I'm one of the editors at the BMJ Leader, and I've kept, up to date with all of the research around unwarranted variation. But we have a huge amount of unwarranted variation, but actually our unwarranted variation in data hides that because we're unable to compare data from different systems, and we're unable to benchmark effectively. And there's recently been a report that shows that between different systems, there's only 22% of data that can be directly compared, so EMRs and so on. And that is a problem that we're living with today, but we need to drive out that variation. And the first step in unwarranted variation is to have the right data without unwarranted variation. So that became a very interesting topic for me. I was then very privileged to do some work with Professor Peter Pronovost, and he actually has quantified in the US the defects in value, as he calls it. So defects in value are things we shouldn't be doing, ineffective care, low value care. And he's worked out in the US that is $1.3 trillion a year, a minimum of that. And, it's similarly large amounts in health systems like yours or like mine. And in essence, there is a huge amount of both improvement in care that we can drive, but also money that we can drive towards new initiatives. And as I said before, I wonder why we didn't have the space, time, and resources to do, new pathways or home-based care or whatever else. His work is aimed at actually driving out those defects in value to make the resources available to innovate towards the new healthcare systems of the future. So I'd really recommend you go and have a look at Peter Pronovost's work. He's fantastic, and he's definitely got some really interesting frameworks to look at low value care, no value care, and so on. And that for me is what we need to do with our data. We need to optimize our healthcare systems. So for me, unwarranted variation in data causes unwarranted variation in care and means that we can't detect unwarranted variation in care as well. So that's something that I think is really closely linked. So the next thing I wanted to talk about was engineering. And, traditionally, the first NHS hospital was really a small set of buildings. And many of us have worked in health systems with legacy sort of estates, if you like. And what our data would look like if we visualize that today is like a set of medieval huts or a rural village. It's very disparate, it's very unrelated, it's very unplanned. It doesn't plan all of the services between it appropriately. And in a world where we're building big, shiny hospitals, the hospitals we build are really well planned. Yeah, they don't look like medieval villages, right? And I was very interested that because we could see buildings, which is one place we deliver care, we design them really well. So we have healthcare planners that design them. So new hospital builds typically, or new healthcare builds, are designed to follow the function that they need to provide. They use a lot of simulation and engineering and so on to make sure that they're the right design. But within our data, because we don't see the data, we don't put that rigor into designing the data systems that support models of care in the way we do with buildings. And I got really interested in this actually because there's a discipline called healthcare planning that helps plan how hospitals are built. And I went back to their academy and I said, what's on your curriculum? I met the guy that led that. And there is no digital or data, or there wasn't traditionally in the Global Healthcare Planning Academy's curriculum. And that meant that both digital and data wasn't considered in designing new health systems or hospitals. And it also meant that digital and data wasn't really being used fully to design, new health systems and hospitals. It also meant that healthcare planning were not sort of informing the data that we needed to collect and provide for the future. But we don't have the equivalent of healthcare planners for data. We don't plan what data we need to engineer or provide. And that's partly why our data is so disparate, why it's, in little silos, and why it's not engineered well for the future. And I became very interested in what we could do about that, because in the way we build hospitals, and they look great, if we could put a picture to our data, it should look as well designed as our hospitals do. And so I've had lots of conversations with healthcare planners. I've had lots of conversations around the future. And we need to put more of an engineering discipline into our data. And I'll come on to a little bit later why that is really important. It's all to do with the fact that data is becoming the new venue of care. So I was really interested in data, and data is for life. And I don't just mean data, it is for supporting life. What I mean is we're coming to a position where we realize that our citizens should be able to have a digital twin or a packet of information that represents them in decision making, or if they're not present, a packet of data they can understand and can empower them. But also the data is there to support individual lives and populations' lives as well. So data supports life, data is part of your life. And increasingly, we're hearing globally about the rights of citizens to have this longitudinal record, if you like, or a digital twin that represents their needs. And we have traditionally procured systems so that they are the cheapest system potentially, or are a system with the best user interface. But what we've not really considered is how those systems contribute for the data sort of landscape, for the life of the citizen, or, for the good of the population. And if we consider the data and how it's come over decades, we design and procure systems very differently. So I'll give you an example. If a baby goes into NICU, high dependency as a baby for a chest issue, that will bear out in that individual's risk stratification for their health for their life. And it will last 80 or 100 years. And it's of use to them. It's of use in many of the healthcare transactions they have. It's of use to the system as well. It's, of use to research. And if we consider that when we procure systems, the primary, the secondary, and the tertiary use of that data over decades, we come out with a very different design and procurement. And we put more weight on the data aspects over decades. So for instance, data now we record perhaps in an EMR with a keyboard, but we'll be using voice in 5-10 years. We'll be using gesture and all sorts of things, passive technologies in 10-20 years. But that data of recorded well is still relevant in 100 years' time. And so we need to think about how that data has longevity and how it will serve our citizens. And so I became very interested in how we buy systems to support the longitudinal record of our citizens and support population health and public health as well. Now, what's really interesting to me is data and what data is. And I think we all know what raw data is, but data has actually turned out to be what's called a capital asset. So a capital asset is something that has residual value. We talked about buildings earlier. And, you know, buildings have a value over decades and you can capitalize them. So that means that you can basically take out a loan to finance them. So you will take out a mortgage or finance to pay for a hospital. Because it has residual value, it delivers healthcare over decades. And actually in the UK now, data and the intellectual property on top of it is considered a capital asset. It's actually called an intangible asset. And the reason that it's considered a capital asset now is it drives value for a healthcare individual's journey or for the health system over decades. It helps with population health. It helps risk stratify individuals. It's, you know, got value that we can use again and again. And as a result of that, actually, in the UK, we can now finance data differently. So as a capital asset, you can finance it in a similar way that, you know, to the way you finance buildings. You can actually take loans out to generate data assets and intellectual property on top of it. You can, you know, give it an asset life of maybe a decade or 2 decades or even longer. And we can actually finance these things with our treasury and the healthcare system as if they were another part of the health system, like a building. And the reason that that is important is it's the new venue of care. So if you look at home-based pathways, self-care, self-management, you will actually find that they are delivered in the home or near the home, but they rely on really good data because the individual is not in front of you. And as a result of that, you can almost think of the data as the elastic walls of the hospital. They're both capital assets, not in every country, I'd say, but in more than one country and increasingly in more countries. And they actually allow more flexible care models. And so as we actually understand that, we start to finance our health systems differently. We start to invest in data, and we also change our behaviors around how we design care, because we realize we've got a new way of delivering care in the home or nearer the home, enabled by data and digital twins and things like that. So it may seem a little bit boring to talk about accounting rules for data, but actually this changes a lot of things. It changes how we finance things. It changes how we view our system. And so really, I feel that data and the applications on top of it are really the elastic walls of the hospital that allow us to pull care into the home or nearer the home. And I think we'll see a lot more conversation around this in years to come. So I'd like to take you now to a slide by EY, and this is something that I contributed to. And they're talking here about where we are today and where we need to be in the future. So today we have lots of silos of data, application and logic. And these are our systems. They say here 200 to 400 systems, but as I said, I had over 1,000 systems. And these systems, you have to join them together. It's like a spaghetti wire of links and interoperability and transformation of data. And, that limits what you can do. It limits the interoperability. And as the research says, between different systems, you only get 22% true meaning or semantic meaning, which means you can only directly compare 22% of the data. EY believe that, in coming years, we're going to end up with a unified data layer. And that means the data can be reused and it maximizes reuse. So data recorded, for instance, in a hospital bed can then be used in outpatients for risk stratification. It can be used in apps or home-based pathways to actually look at potentially, say, dosage of a drug that an individual needs. And around that, we're going to have lots of new data types in the data layer. So we'll have things like apps, wearables, sensors, medical devices, all coming in around that actually generate data, but use the data as well. And we'll have AI, which is really the coming sort of revolution that is forcing us to standardize our data. And then there'll be logic units as well. So things like decision support and so on. And what we need to do is move from this very disparate landscape with far too many systems and far too many definitions to a more unified layer where data can be reused many times and can travel with the individual for their life. And that's the sort of view that EY have of where the future is going. And I'm very hopeful that we're starting to converge on standards that allow this to happen. But from my perspective, if we continue on the path that we've gone on, then all of this data from the new data types, the apps, wearables and sensors, social determinants of health, will add further complexity. And we're already at cognitive load. Our brains are full already and it's unmanageable. We need to do something to engineer this well for the future. So I don't know if many of you have actually looked at the World Health Organization's toolkit for health. It's a good document. And I took the different standards from that toolkit and just put them in quite a simple diagram here. So as we converge and try and standardize our data, there are lots of complementary standards. So in the interoperability and workflows, we have HL7 and IHE. Sitting between interoperability and persistence, we have FHIR. Then within the data model and data persistence, we have OpenEHR and OMOP. Then in terminology, we have the likes of SNOMED, CT, LOINC, and a few others as well. I'm sure in your environments, you'll have your own reference values. And if we put all of these together and converge on these standards, which are complementary, because at OpenEHR, we work with all these other standards bodies now, we can start to drive a longitudinal record and a digital twin, which will last for the life of our patients and will also serve the healthcare system. It will help us to drive out those, defects in value and the unwarranted variation in healthcare. And part of the drive that myself and many others have got is to try and converge on these standards. It's not an easy journey because we have a lot of legacy, particularly in systems like the NHS that I'm from. There's a huge amount of old systems that don't conform to this. But over time, we need to converge and we need to be able to provide data that is standardized. And so I just use this little diagram to simply show people where we should be moving, because the World Health Organization has done a very, very long paper on this, which takes a lot of reading. But this diagram just helps people understand where the convergence should be and how we should converge. And my view is that we would have a data platform which is distributed, but allows the data to be dynamically pulled together for individuals to allow this healthcare journey to be safely undertaken. So if I talk about EMR, excuse me, looking at EMRs, I think all of us will have worked with EMRs or know what EMRs are, the electronic medical record. The first generation in many countries was the cheapest solution, as I said. It was tactical and limited interoperability. We bought it because it was cheap We bought it because, you know, it met the needs of one organization, and you know, there was very limited interoperability. So the best of breed was the first generation. So you might have, you know, 15, 20 systems that are sort of meshed together, but they don't fully interoperate. And we then moved to the second generation. And the second generation was one large EMR. So certainly in the UK and the US and a few other countries, we bought one big EMR, and we tried to do everything in that EMR, and it had its own bespoke data model. But we found that you know, the data was not accessible, and that, you know, it wasn't flexible for innovation. Now with the third generation, we are looking at federated, and this is where we focus on data as the core, and it's well engineered for all care settings. It gives the, you know, longitudinal standardized data, supports value-based care, and it allows participation from the citizen in innovation. But it's adaptive and additive, so we can move forward, and it's orchestrated and modular. So it allows us to, you know, adapt the system. But importantly for me, in my role giving advice to governments on AI, it's AI ready. And the reason that it's AI ready is it's clean codified real-time data, because all of the evidence is that for AI, especially for large language models, you need really good data that's standardized. There's a misconception that you're able to use, you know, tools like natural language processing and other things to pull out your data for AI. And that is not right. All of the evidence that I have seen says the better the data and the more standardized the data, the better the AI is. So for the cognitive age, for the AI age, we need to move into this third generation of data from the EMR, which is about being able to orchestrate in a data environment. So the cognitive age, as I said, it's very interesting, because the cognitive age is the age that we're now in. And, you know, I've done a lot of work around AI and training models. And what we're finding is that if we get this right, we can form global communities around AI. And we don't have to lose data sovereignty or compromise our citizens' data. There are distributed learning models that can actually reach into data repositories if they're standardized in different countries and learn across those repositories. Now, this is one example I put here in the slide around distributed learning and AI for healthcare. And it talks about how, you know, globally we can have different repositories, say for rare diseases or cancers. If we standardize the information, we can use distributed learning, and we can actually do things that we've never done before if we get this right. So that's another reason for standardization globally. In the case of rare diseases and cancers, in any one country, you may have very small groups, but globally, we have enough data to gain insights and improve, you know, treatments for individuals and groups. And this is a very exciting horizon, which is one reason why we need to work together globally on standards for healthcare. So what is OpenEHR? I've talked a lot about my journey and how I came to OpenEHR. But OpenEHR is a community, and it's you know, operates in 114 countries. You have individuals in 114 countries. We create clinically led models and a platform for semantic harmonization of health data. So what does that mean? It means that we're creating a object-oriented, if you like, model for all of the healthcare information that you need about the human condition. And we also provide open source tools such as an open source CDR, so you know, a repository for that data, where people can actually start to work on, you know, standardized data. There's a standard architecture, which is future-proofed. So it's designed and engineered for the data to last decades and have meaning over decades. And it offers a path away from these silos of data to a longitudinal patient-centered record, which supports life and improves life. It also gives the ability to power the AI age and provide digital twins for our citizens. So really it's an initiative to, if you like, engineer data well for decades. So if you could visualize your data, it would look like a well-engineered hospital in terms of buildings. And we've got some pretty big names, people like EY, Microsoft, Daedalus, and many more involved. But we've also got many hundreds and thousands of individuals across the globe who are contributing to this. Some of them clinicians, some of them engineers, some of them patients. And the aim here is to create a community where everybody's voice matters and everyone can contribute. And we've got some fantastic contributions from Africa, from India, from other countries, where we've got, community members who are driving forward initiatives and making sure that we are mapping all of the data that is needed for healthcare in a way that is consistent across the globe. Now, OpenEHR, as I said, is a community, and we are a total not-for-profit. And you can actually see here on the picture, the chap with the white hair is Professor David Ingram. Now, David was the founder of OpenEHR, and he started the journey at University College London back in 1991. So this has been many decades in the making. He started this to look at how we should engineer data well. And he has then grown this community, and I've now taken on the job of CEO with OpenEHR in order to, grow the work that he has done. And this is a picture that was taken from one of our many conferences. It was one of the conferences in Catalonia this year. And Catalonia is moving to OpenEHR, and it looks like Spain will be adopting it nationally. We've got a centre of excellence being set up in the NHS, in the UK, to actually take forward OpenEHR. But we're finding countries like Jamaica and Nigeria are also moving to OpenEHR as well for many of their data needs. And OpenEHR itself, you can start as a greenfield country and use OpenEHR as a data model, or you can normalize data into OpenEHR from existing systems, and different places in the world are approaching it quite differently. But we'd really welcome anyone that wants to join us as a member, because it's €20 a year. We're a not-for-profit, as I said, but we have very many individuals who pay those €20 a year and then join the community and collaborate and find much benefit from being part of the group. It's a group that, collaborate, as I said, on many initiatives. But actually, it's free to use OpenEHR's data models. So for all of those globally who don't necessarily want to be part of the governance and participation, if you have an innovation or, if you're working on a healthcare problem, you can just go to the OpenEHR website and look at the models that have been created by clinicians globally and peer-reviewed and fed back on, and actually put those into your developments. So there is no cost to use the OpenEHR technology and data definitions. That is all free under the Apache license as a good for healthcare globally. So I would encourage you, if you'd like to come and join us, because it's an amazing community, but equally, there is no commitment to pay. You can just use what we have for free if you want to, investigate or understand a bit more about, data models in healthcare. Now, we have a number of people who are active in your geographies around OpenEHR, and we have a number of what are called affiliates as well. So affiliates are geographical based sort of chapters of OpenEHR, where people create real solutions. And if you're part of the OpenEHR community, you can join a local affiliate if you've got one, or you can set one up if you don't. And those affiliates spend time together building solutions for local geographies and local needs, and creating ecosystems where people can meet and collaborate. And it's lovely. We have 14 of those around the globe, with more coming on board, making us a truly global community. We're also joining the JIC early next year. So the JIC is the Joint Initiative Council, and that means that we will become collaborators with HL7, with IHE, with SNOMED, with LOINC, and many others. So we're going to become part of that international standards landscape, and also working with ISO as well to further strengthen our ISO status. We're already aligned with ISO 13606, but we will be aligning with further of the standards. So that's really a bit about my OpenEHR journey and how I got where I got, and why I'm part of OpenEHR. But I'd just like to leave you before we go to questions with this slide. And on this slide, you'll see a man, and his name is Professor Ian Buchan. And he's someone that I work with in Manchester. And we undertook a learning health system called Connected Health Cities, where we created an account of how many lives were saved or improved with data. And we called it Data Saves Lives. And without that initiative, I would not have really taken this data journey. But as I understood how much we were able to save lives or improve lives with data, it became very real for me that this was important for me to do globally, and that all of us need to take data a lot more seriously in terms of its impact on health systems. So thank you, and I will move now to questions.
Yes, thank you so much, Professor Rachel. So to our participants, our floor is now open for questions. You can enter your questions in the Q&A box or the chat box. We've also enabled the microphone, so if you'd like to ask your question directly, you may also do that.
Or feel free to unmute and ask away. I'd be super keen to know a bit more about where you're all from. Daniel Rosen, is there any relationship between OpenEHR and OpenMRS in Bomini? No, Daniel, at this point, there is no relationship between the two. There's also another initiative called OpenEMR, which is actually an open source EMR. While we track those initiatives, we don't have any reciprocal agreements with those arrangements. If you like, we're really a standards body about the data definition that provides an open source clinical repository for people to start work on. But we don't directly work with those initiatives at the moment. So thank you for that, Daniel.
Yes, there's a new question, Professor. It's from Dr. Anjan Taha. The question is, if using open source EMR, can it ensure data privacy and security?
Thank you. Yes, so data privacy is very important. And we talked about the federated model earlier. Now, there are various tools that can be used on top of OpenEHR to ensure data privacy. And one of the tools that I've used is Snowflake, but there are others. And what's really important for data privacy is two things. One, sort of access control based on roles or jobs. And that's what I've used Snowflake for in the past. The second one is transparency, to make sure that citizens or organizations have got transparency about who has used data and how they've used it. And using OpenEHR itself is the data repository, but there are many complementary tools that you can use on top to ensure privacy, security, and transparency. And, you know, I have used some of those across a city region with 38 organizations to ensure that we provide, you know, all the assurances that are needed to our citizens. So OpenEMR itself does not have that security module in, but there are many modules out there in the market that you can use at the federation layer to ensure the privacy and security. And they can be tailored also to deal with your local needs in terms of things like data protection, sort of annotations. So in our case, we would record, say in the UK or under GDPR, which data sharing agreement the sharing happened under. And those tools enable you to do that. So that's really how it is dealt with. But it's a really good question because data privacy and security has to be built into the solution sets that we have. And it has to be on everyone's mind, especially with the complexity of data now and also the amount that it's been used by different systems. Good. Yes, so Thep here is asking a question about sharing a health record. So I think, yes, I do have experience across the city region. So sharing data, federation, as I said, if you store things in the same format, you can federate easily with it and identify for the patient. And one of the best examples, one that I've worked on most recently, is the One London record. So it's all of London, 12 million people. And all of the care plans are actually stored in OpenEHR, and they're stored in a federated manner. And that is a shared care record. And it is absolutely possible to orchestrate that because of the fact that you're storing the data in a consistent format in different places. And so Thep, I think the best place for you to look is the London Care Record, because that's a very complex environment, but with between 20 and 30 organizations where the data is being presented in a shared care record. And it's complex data across multiple agencies for care planning and health and social care, as well as third sector. So yes, it's the right technology to use for this because it standardizes the format of the data. Yes, and thanks. We just got a confirmation there from Shinji that yes, you can use open source EMRs to ensure data privacy. So that's good to know. Daniel, is EHR base or EHR server FHIR compliant? So yes, EHR base is. I was on a call this morning with Stefan Schraps, who leads the team. EHR base, for those of you that don't know, is our free open source CDR, so clinical data repository. And that has FHIR APIs on top. The really great news is that we're just working through with Graham Grieve and the people at FHIR some of the work that we have done to standardize the FHIR interfaces on top of OpenEHR. And also we have OpenEHR on Smart as well as Smart on FHIR. So we've aligned Smart, which is authentication for FHIR, across OpenEHR in the way that it's aligned with FHIR. So you can create applications coming from both FHIR repositories and OpenEHR repositories that unify the data. So we're working very extensively on those things, and we're getting even closer to HL7 and the FHIR community in formal ways. So yes, EHR base does have FHIR APIs, but our other initiative around Smart on FHIR is allowing apps to be written across both repositories and meshing that data together. That's a really good question. So Anjan, thank you. Open source EMR can ensure interoperability between local and global organizational health record. So there are open source EMRs like OpenEHR. We are OpenEHR, so we're the data layer. Yeah. And in saying that we have semantic harmonization here, we are ensuring that the data is recorded in exactly the same format. And as you ask about interoperability between local and global organizations, if you stored the data about a human being across the globe in one way, you would be able to dynamically pull together a digital twin or a longitudinal record of that individual. And at the moment, we're talking a lot with people like the European Health Data Space about these principles, because the main thing that stops us pulling together a global health record for a citizen are the thousands of different ways the health record could be stored across the globe. And in real time, we can't safely put that together. And indeed, as I said before, only 22% of it would really go together anyway. We'd be losing a lot of that data. So the aim here is to make sure that we do have a global record. And part of the aim here is to make sure that people can travel globally or seek treatment globally, and that record can travel with them. But really, it's not the open source, not the EMR, not the screens, not the ordering of tests. It's all about the data layer being consistent. That's the most important thing, and that's what OpenEHR deals with. OpenEHR itself, is really about an EMR and the functionality for a hospital or a community, where you get the screens. We're more at the data layer, where the data layer that will last for the life of the citizens. So yes, it is really about creating a global health passport or a digital twin you can take around the globe with you. Okay, any more questions? And to Dr. Akshi, I left my email on the presentation. Please feel free to drop me an email. It'd be great to talk further with you. Okay, Thep has asked, is it easy to customize to local languages? And yes, the answer is it is multilingual. And so we have this in Norwegian, we have this in German, we have this in, Gujarati, we have this in many languages. And the whole point here is that the healthcare record itself should be codified, and it should have a terminology in it, and it should be accessible then in multiple languages. So yes, we do absolutely support multilingual, and it is used in many languages now. Right, next question. Churito, does open source AeHIN support customization and meet specific needs of workflows? So we are not the EMR, and there are open source EMRs. We are the data layer, and there are many companies that provide EMRs on top of OpenEHR, which is the data layer. And many of those companies provide low or no code toolkits that can allow you to customize workflows. So really, this is about getting the right data layer and then allowing flexibility on top. So absolutely, if we talk about Better or Vita Group or others, they have low or no code toolkits on top that allow you to customize your workflows. A great example of that is in Nigeria, where they've got community system in low or no code on top of OpenEHR. So really, it changes the paradigm. We're building the data, making that great, and then building utility on top of that. Okay. Shinji is asking, is there a global outreach plan including Asia? So we have members from across the globe, and we welcome any new members. We welcome any new chapters. The outreach plan is we will support any chapters who want to use this. But with OpenEHR, what I would say is we're not commercial. And so we're not going to do a market entry plan, or we're not going to do a sort of commercial drive to do this. We found it's very organic. And it's people like me that have worked in health systems with a clinical background or a semi-clinical background who begin to understand about data engineering for healthcare and then embrace this. And so, Shinji, I would say that what's happening here is it's not an outreach plan, it's a global pull from health systems who realize that data is key and realize they need to engineer data. And then we engage with those people and we support them in taking the journey. So as opposed to us pushing, it's about a pull from communities and a pull from people who want to make data right for the future of healthcare and want to make it fit for the future and fit for the AI age. And so we welcome any of you, becoming part of the community, and we welcome any affiliates being formed as well that will drive it forward in your region. But because this is free and because this is a complete not-for-profit, the aim is not to be commercial or to push, but to support those that want to do the right thing. Okay, so Samson, you have an education program. Can you share a bit about this? Yeah. So, you know, I've been a professor. I've run university programs at Imperial, Edinburgh and Harvard. So I've got a good education background as well. And within OpenEHR, we've set up some programs that will allow you to become, you know, educated in OpenEHR, that will allow you to become an educator yourself if you know, become really competent at this, and will also allow us to certify professionals. And this program is out there, but again, being not-for-profit, we welcome others who are creating educational materials to come forward and participate. And we don't sell the education. What we do is we certify offers from our community so that people know it's good quality. And so there is a marketplace, if you like, of people that have been certified that we've found of a high enough quality that we give a kite mark to. And the aim here is to allow anybody who is an educator, be it a university, be it an individual, be it, you know, somebody in the community, for us to certify that they are providing good quality materials, and then people within the community can know that that is a good educational offer. So for us, it's really, again, about, you know, a democratization of the education and making sure there is a whole set of offers that we have checked into and feel are of a good quality. So do OpenEHR offer a free training on data standardization for members? So we don't offer a full free training. And I would say actually that if you're going to go to the really advanced levels in this, it's probably university-based education. So I teach this at universities. And I have, you know, even more advanced practitioners that teach at universities. So we don't provide that as, you know, a free good, but we certainly can point people towards, you know, programs at universities or from educators or from consultants that will allow people to take the journey of data standardization. And the reason it's quite hard to provide a free offer is the baseline that so many people come from is different. Are you a greenfield, a brownfield? You know, it's so different across the globe. And so we don't have a free offer, but we certainly can point people in the direction of offers that will help them take that journey. And, you know, certainly within the UK, I have taught over 500 clinicians and senior leaders about, you know, data architectures for the future, but that's been via universities. Okay, well, I think we're coming towards the end. But thank you all for listening, and thank you for the wonderful questions. There's some great questions there. And I'd really welcome your feedback on LinkedIn or anywhere else if you want to get in touch, and we would welcome you, as I said, as part of the community.
Yes, we're nearing the top of the hour. Thank you so much for helping us learn about OpenEHR, Professor Rachel. And we hope to have you again on AeHIN Hour and other AeHIN activities. Also, thank you to our participants for actively participating in tonight's session. We hope you also enjoyed learning from Professor Rachel. Thank you again, everyone.